Good morning. We'll start with the talk on management algorithm for orbital infections and infestations. So in 1963, Chandler, who was an otolaryngologist, classified the orbital complications of sinusitis into 5 stages, and it's still followed today because it's very simple and sensible. So the 5 stages were: 1, preseptal cellitis, where the inflammation is present only anterior to the orbital septum. When the inflammation proceeds posterior to the orbital septum and both the muscle and the fat is involved, it causes orbital cellitis. Sometimes you get pus collection between the periosteum and the bone, most commonly medially adjacent to the ethmoid sinus, and then it becomes a subperiosteal abscess. And sometimes the pus collection is in the intraconal space when it's called an orbital abscess. Rarely, the infection spreads to the CNS and the body tries to limit the infection by causing a clot within the cavernous sinus, and this causes a cavernous sinus thrombosis. So coming to each of the stages, first simplest stage is the preseptal cellitis, where you have inflammation, localized warmth, erythema, edema of the eyelid, caused by a local focus of infection like a furuncle or a style. But when you open the eye and examine, the conjunctiva will be clear. There will be no proptosis, extraocular movements will be full and free, and usually vision is normal, no color vision defect or RAPD. The corresponding imaging will show edema in the superficial region only. The orbit will be healthy. So how will you manage mild preseptal cellitis? You can give oral antibiotics and keep the child on daily follow-up. However, if it is severe, treat as an almost orbital cellitis, hospitalize the child and start IV antibiotics. So next, when the disease becomes more severe, the patient will present with proptosis. Extraocular movements will be limited and painful. Conjunctiva will be chemosed and congested, and the patient is usually febrile and in severe pain. Vision may or may not be affected. There may or may not be RAPD depending on optic nerve involvement and color vision involvement similarly. And imaging will show proptosis. This is the defining sign between a preseptal cellitis and an orbital cellitis. And how will you manage? Orbital cellitis should be managed as an emergency. Hospitalize the patient immediately. Send for cultures, blood cultures, and an immediate CT, preferably contrast enhanced. And start on broad spectrum antibiotics like cephalosporin, third generation cephalosporins. If does not respond within 2 days, start on metronidazole and a low dose amikacin also. Get an ENT opinion and do a FS, because 90% of orbital cellitis is due to sinusitis, and 90% of sinusitis will be ethmoid sinusitis. If the patient complains of headache or there's a history of seizures, ask for an LP as well. So unlike bacterial orbital cellitis, fungal orbital cellitis occurs in a severely sick patient, usually a diabetic with ketoacidosis. Now fungal orbital cellitis is most commonly caused by mucor, which is a fungus characterized by aggressive angioinvasion. So a patient presents with a blocked nose, severe facial pain and facial edema, and a painful proptosis. And sometimes in the late stages, you get eschar formation. Eschar formation is initially seen on the turbinates and the nasal mucosa. Later, it can appear on the skin, and facial eschars on the skin is a late sign and a poor prognostic sign. Here also, the imaging of choice is a fat suppressed diffusion weighted MRI with the characteristic avascular middle turbinate, and that is called the black turbinate sign. And diagnosis is always by histopathology, where you have to see the broad ribbon-shaped hyphae involving the vessels also. Management is tri-pronged, and simultaneously you have to control the risk factors. For example, in a diabetic, you control the hyperglycemia and the acidosis. At the same time, start the patient on IV liposomal amphotericin. If MRI shows involvement of the orbit, especially close to the apex, you can give a retrobulbar amphotericin injection. Get a ENT opinion and do a FS as soon as possible to do surgical debridement of the affected avascular tissues. Aggressive debridement is necessary. And if there is histopathological evidence of mucor and MRI evidence of orbital tissues, and you are anticipating CNS involvement, then you can always think of an excineration. So sometimes, especially in children, Even after 2 days of treatment for orbital cellulitis, the patient fails to respond and starts to develop an eccentric proptosis. When you examine the patient, you may feel a palpable swelling along the orbital rim. So again, ask for an imaging, and you usually see a subperiosteal abscess, most commonly along the medial wall. Sometimes adjacent to the frontal sinus also, where you get a superior periosteal abscess. So how will you manage? Because it's mostly in the pediatric age group. For a child less than 9 years, mostly gram-positive organisms are responsible. So you can try just conservative management with IV antibiotics. Surgical drainage only if there is evidence of optic neuropathy. And for the child more than 14 years, you get mixed organisms. So always consider surgical drainage with IV antibiotics. However, in the intermediate age group between 9 and 14, it is selective. So mild cases you can manage conservatively with IV antibiotics. But consider surgical drainage if the subperiosteal abscess is large and non-medial, if it is associated with frontal sinusitis, if you suspect an anaerobic pathology or an odontogenic infection. And always if there is optic neuropathy, again consider surgical drainage. And if there is reaccumulation of pus in the subperiosteal space, and if it's a patient with chronic sinusitis, nasal polyps, etc. So these criteria was put forward by Garcia and Harris. And surgical drainage is usually external drainage, endoscopic drainage is also possible, and a combined procedure is also possible. So in adult patients, suddenly the patient with orbital cellulitis may present with an exacerbation of the proptosis. The conjunctiva becomes more chemosed, more congested, and the patient is in severe pain. The periorbital edema is also more. And when you examine the patient, the fundus will show a papilledema with congested veins, and now we suspect an orbital abscess. So again, the investigation, you send for MRI and you will see a pus collection in the intracornal space. Surgery is always required. Drain the abscess through a superior and inferior orbitotomy, or if it's localized to some quadrant, you can do an anterior orbitotomy in that particular quadrant. IV antibiotics has to be changed. Whatever you're using, use a more powerful drug like vancomycin or linezolid. Surgical debridement of the necrotic tissues can be done. And if you suspect CNS involvement, you can always consider exenteration. Now sometimes when the patient is kept on follow, all orbital cellulitis patients have to be reviewed every 4 hours. So sometimes the finding becomes bilateral. So periorbital edema, chemosis, proptosis, limited extraocular movements in the other eye develops, and this imaging will show cavernous sinus thrombosis, that is congested superior ophthalmic vein and inferior ophthalmic vein. The lateral borders of the cavernous sinus become convex and absent flow void will be there. So then the management includes antibiotics, systemic steroids to control cerebral edema, anticoagulants to control the thrombosis, and anti-epileptics. So this will be managed by a neurosurgeon or neurologist. And orbital infestations that are commonly seen are cysticercosis, ophthalmomiasis, dirophilaria, etc. Definitive treatment of all cases of parasitic cyst is removal of the parasitic cyst. So cysticercosis is mostly seen in the ocular adnexae or the muscles, and the muscle most commonly involved is the superior rectus. If surgery is not possible, then you can give a long-term course of albendazole, 15 mg per kilogram per day for 2 weeks along with steroids. And ophthalmomiasis, manual removal of the larvae is required. You pack the damaged orbit with 4% silocaine and turpentine oil to immobilize the larvae and manually remove it. Again, if the tissue destruction is extensive, do an exenteration. And single dose ivermectin can also be given. And dirophilaria does not involve the orbit primarily, usually causes a subcutaneous nodule. But again, excision of the nodule is necessary with single dose ivermectin and 3 doses of DEC. Other rare infestations are trypanosomiasis, leishmaniasis. Not strictly speaking orbital lesions, they present with periorbital edema, lid swelling, etc. Rhinosporiosis can be present in the nasolacrimal sac and present as an orbital swelling. Similarly, trichinosis can present in the extraocular muscles, etc. Thank you.
Thank you, ma'am, for this informative talk. Now I would like to invite Dr. Soumya Narayanan. She has completed her DNB in ophthalmology and fellowship in orbit and oculoplasty from Agarwal Eye Hospital and Research Institute, Chennai. And currently she is working as a visiting oculoplastic surgeon at various hospitals in Calicut. She'll be talking on when thyroid is the culprit.
Good morning all. So when a patient comes to your clinic with these features like lid retraction with lateral flare, lid lag, proptosis, periorbital fullness and fat prolapse, conjunctival congestion, exposure keratitis, extraocular muscle restriction and compressive optic neuropathy, you will be thinking firstly of thyroid. So thyroid eye disease is an autoimmune disorder affecting the orbit mainly in the 3rd to 5th decade with a female preponderance, and it is mostly associated with hyperthyroidism, and it can also occur in patients with hypothyroidism and euthyroidism. So the pathogenesis, the main culprit is the fibroblast, where there is insulin growth factor receptor and TSH receptor. The corresponding antibodies are being attached to the receptor, and the orbital fibroblast will proliferate and form fibromyoblast. It will produce more of fat and glycosaminoglycans, and there is a inflammatory cascade by the T lymphocyte. So all these things will lead to the above mentioned symptoms and signs. So for evaluation, we need a complete ocular evaluation including diplopia charting and visual fields. Thyroid function test should be done along with a thyroid peroxidase enzyme and thyroglobulin antibody, and rule out any other autoimmune disorders. Imaging in the form of B-scan, CT bar, MRI orbit or USG neck is also important. So in the imaging, you can see there is fat hypertrophy, muscle enlargement, radiological activity in the form of inflammatory edema, and also we should look for apical crowding, especially in, like Barrett's index or effacement of the perineural fat by the muscle. So Rundle's curve is actually gives us the natural course of the disease, where it has an active phase and a quiescent phase. In the active phase actually lasts for 1 to 1.5 years, and in that time, if you can intervene effectively, we can reduce the impact of the disease. And later, when it is in the quiescent phase, we can do reconstructive surgeries if needed. So thyroid eye disease, the two important questions is whether the patient is in the active phase or in the quiescent phase, and also in what type of severity the patient is having. So for clinical activity score will help us in seeing whether the patient is in active phase or not. So in the first visit, we have to look for any pain or pressure over the periorbital area, pain with eye movement, swelling of the eyelids and conjunctiva, redness of the eyelids and conjunctiva, inflammation of the caruncle and plica. So if the score is more than 3 out of 7, it is considered to be active. And the follow-up visit, along with the 7 measurements, we also look for any increase in the proptosis, decrease in the eye movements, and also decrease in vision. So out of 10, if the patient is having a score of 4, we have to consider it as an active disease. So severity is classified by the UGOGO, where it is mild when there is a mild proptosis and lid retraction, and moderate to severe and sight-threatening in case of dysthyroid optic neuropathy and severe exposure keratitis. So this is a protocol by Dr. Santosh Honawar, published in IJO. So in the active TED, we have to see if the patient is in mild severity, we can use conservative measurements like controlling the thyroid status, lubricant, oral steroids, ask the patient to quit smoking. At this stage, the patient is having severe lid retraction. This time itself, we can give a intra-LPS steroids to decrease the lid retraction. And in case of moderate to severe active thyroid eye disease, we can give a low-dose IVMP pulse therapy. If there is good response, we can wait. And if it is suboptimal, we can, along with the IVMP, we can also add low-dose radiation and immunomodulation. And if the patient is having severe sight-threatening disease, high-dose IVMP pulse therapy is given. If there is good response, we will continue with the immunomodulator therapy. And if it is suboptimal, we have to go for early decompression. When the patient becomes inactive, we can go for the sequential surgeries. So in the 2021 UGOGO meeting has said that we can even use mycophenol mofetil as the first-line treatment. It has equal effectiveness as the IVMP treatment. So methylprednisolone acts on the fibroblast, B cells and T cells to inhibit the pro-inflammatory substances. And immunomodulators like mycophenol mofetil, cyclosporin, azathioprine and methotrexate can also be used. either as a adjuvant therapy, or in the case where the patient cannot take an IVMP, we can go for these treatments. So there are targeted therapies like the revolutionary intervention is that tripotunab, which is affecting the insulin growth factor receptor. So this is actually, the studies are showing it has same efficiency as the decompression. We can also use rituximab, which is targeted against the CD20. Others are tocilizumab, blocking the interleukin-6, infliximab, adalimumab, and etanercept. So orbital radiation can also be used as a adjuvant therapy when the IVMP management is not effective in patient. So it is given as 20 Gay in 10 divided doses over 2 weeks of time. So to conclude, if the patient is in inactive stage, we can also do surgical management if needed in the order of orbit, lid, EOM, and lid. Thank you.
Thank you very much, Dr. Soumya. Next, I call upon the Chief Instructor, Dr. Aparna. She's completed her fellowship from Aravind Eye Hospital, Tirunelveli, and currently she's a consultant orthoplastic surgeon at Chaitanya Hospital, Trivandrum. She will be talking about orbital inflammatory diseases, a Pandora's box. Over to you.
Good morning. Today let's try to decode orbital inflammatory diseases. Orbital inflammatory disease is an umbrella term that represents an etiologically diverse spectrum of conditions unified in their association with abnormal inflammation in the periorbital region. Presentation in 80% can be an acute onset of signs of inflammation, but in 20% cases it can be subacute with mild pain, and it can present as a mass lesion also. Rootman has classified it into two groups: specific inflammatory diseases and non-specific or idiopathic orbital inflammatory diseases. Specific can be due to specific causes like sarcoidosis or vaginous granulomatosis. Non-specific ones are space-occupying lesions which are non-neoplastic and non-infectious. Basically, it is a diagnosis of exclusion. Based on location, in IOID can be classified into diffuse or localized, as in myositis, dacryoadenitis, perineuritis, apical, and anterior. The common one, myositis, that present with an acute onset of painful eye movements, congestion, chemosis, like that. Imaging shows muscle enlargement with involvement of the tendon. Dacryoadenitis, patient will present with congestion, then tenderness over the lacrimal gland area, enlarged lacrimal gland. In about 30 to 50%, it can be associated with systemic conditions like lymphoma, sarcoidosis, GPA, Sjogren's, like that. So high index of suspicion is needed for systemic investigation and biopsy in case of dacryoadenitis. This patient who presented with multiple episodes of lacrimal gland area involvement, so we did an excision biopsy. Histopathology showed plasmacytic inflammation with storiform fibrosis, and immunohistochemistry showed IgG4 positive cells. So it is a new kid on the block, IgG4 ophthalmic diseases. Diffuse orbital inflammation is usually unilateral, present with repeated episodes of proptosis and ophthalmoplegia. It can be associated with reduced vision if there is associated perineuritis. Coming to the diagnosis, whether it is myositic or non-myositic, we have to do an imaging, radiological evaluation to know what it is. And we have to do some blood tests that I will be discussing later. And if it is myositic, we can directly start a trial of steroids. And if it is responding to steroid, that we can include as a diagnostic criteria. Then if it is myositic, like lacrimal gland involvement or atypical involvement, we have to do an incisional biopsy in order to rule out associated systemic conditions. Blood investigations, if there is elevated CBC, ESR, or CRP, we are dealing with an infective etiology. Then before starting steroids, we have to do blood sugar levels and rule out tuberculosis, especially in our areas, endemic areas like our place. Then we have to do ANCA, AC inhibitors, ACE, then IgG4 disease. If there is muscle involvement, we have to do a thyroid function test, because we know in thyroid eye disease there will be sparing of the tendon, but there is certain scenarios that can involve the tendon also in thyroid eye disease. So whenever there is muscle involvement, we have to send for TFT. Then if there is lacrimal gland involvement, we have to send anti-Rho or anti-La for Sjogren's disease, then RF factor and ANA profile. Then investigation, we have to do either CT or MRI, which shows that site of involvement like enlargement of extraocular muscles, enlargement of lacrimal gland, perineuritis or a tenonitis. Then if the patient is in conditions which are not responding, if it is showing a recurrence, if it is atypical involvement or non-muscular involvement, as in case of lacrimal gland involvement, we have to do a biopsy. And if the patient is already on steroid, we have to wait for a period of 2 weeks. And what is expected in a non-specific orbital inflammation is lymphocytoplasmic infiltrate with a mixed pattern of cells. But if there is vasculitis pattern, we have to think about GPA, send for INCA, look at the paranasal sinuses and renal function test. If it is granulocytic involvement, we have to rule out tuberculosis, sarcoidosis and fungal infections. If it is showing sclerosing pattern, think about IgG4 disease. About the management, in mild cases, we can start a trial of NSAIDs. If it is a classic pattern, we have to start, we can start oral steroids, but make sure we have to give a full dose and we have to taper very slowly, because if we are under treating and if the condition is not responding, we may be clueless whether it is due to the under treatment or if it is something else which is not responding to steroids. And in case of intolerance or atypical cases, we can start with IVMP or immunosuppressants. The sclerosing variant, which shows poor response, may need immunosuppression or a radiation therapy. Methotrexate is a relatively safest immunosuppressant, but in cases like GPA, which can be life-threatening, we have to give immunosuppressants like cyclophosphamide. So this elderly gentleman who presented with features of inflammation, without imaging, somebody has started on steroids, but on imaging there was a huge mass which was crossing the midline, so we did a biopsy. It was a non-Hodgkin's lymphoma B cell type. So sometimes orbital inflammation can masquerade the underlying neoplastic conditions also. So my take-home message is, we have to take a detailed history and meticulous clinical examination is must, and do not hesitate to do a biopsy when it is indicated, and do not undertreat when you are giving a trial of steroids, because that may make you clueless regarding the further steps in the management. Thank you.
Thank you, Dr. Aparna. Next, we have Dr. Annie Sridhar, who is a consultant oculoplastic surgeon at Little Flower Hospital, Angamali.
So I think the dictum is, if there is a mass biopsy, that's what Dr. Santosh always used to say. So slight deviation, I'll be dealing with orbital trauma. So Angamali is situated at the crossroads between the MC road and the highway. So we have lots of cases, lid tears and orbital tears. So orbital trauma includes blow-out fracture, which is a floor fracture, blow-in fracture, medial wall or superior wall fracture, that is the bone bends into the orbit, and orbital apical trauma. So floor fracture, as you all know, involves more the medial part of the floor, that is medial to the intraorbital groove and foramen and nerve. So floor fracture is more, orbital floor fracture is more common than rim fracture. In my experience, I have seen only 1 or 2 cases of rim fracture. But if there is a rim fracture, you have to look at the pupil, because the inferior oblique can be involved and the pupil fibers go through the nerve to inferior oblique. And also in all cases, you have to test the sensation in the infraorbital area. So these are the 2 theories, hydraulic theory and buckling theory, used in theory and in practicals, but I still don't know what these theories are. Maybe the younger generation will know. So in children, the fractures are white-eyed because the eye is white and quiet, and because in children it's a green stick fracture like thing, where the bone just bends and then traps the inferior rectus in it and then closes. So there is no bleeding, there is no ecchymosis, it's a white-eyed fracture. But in adults, there will be a ecchymosis, edema, crepitus, etc. because it's a large fracture. And see, in children, you can see that's a trapdoor fracture. The inferior rectus is trapped there. So what happens when the inferior rectus is trapped? There will be the oculocardiac reflex. There will be vomiting and bradycardia. The child is usually admitted in the neurosurgery ICU. So, and nobody will test the movements. This is the teardrop sign is what is the classical sign when you get a trapdoor fracture. That is the inferior rectus or the tissues around the inferior rectus will be entrapped. So in adults, the bones are mature, so they'll break and the fractures will be large. There will be tissue prolapse. There may not be any entrapment. So in children, after a fall, if they have vomiting, bradycardia, nobody will be testing. So if they have a vomiting and they are admitted in the neurosurgery ward, you should always, when you're called to see the patient, always test the ocular movements. This child, the movements, the head tilt, masqueraded the ocular movements and the squint, and the child, it was detected only 1 month after the admission. And you should always take a CT scan of the orbit. The brain CT will not reveal the actual fracture. So always include orbital cuts along with the brain CT. And so what are the indications for imaging? If you have an ecchymosis, or if you have a crepitus, or there is lid edema, large lid edema, you have to image the patient, or if there is epistaxis. So whenever the globe is ruptured, we all concentrate on the globe rupture. You should check the ocular movements, because these fractures, even I have not detected it many times, because you do not take a CT. Medically, these may have implications. Even though the child and the eye may not get any vision, the fracture has to be detected. So you have to cooperate between the neurosurgery, facial-maxillary and the ENT departments. Depression may also be affected in inferior rectus entrapment and floor fracture, because the fracture may extend posteriorly. So earlier a conservative approach was advised, and even now in large fractures you can wait for the edema to subside down and do a repair in large fractures. But in trapdoor fractures, surgery should be done within days. You can go you can go either through a subciliary or a conjunctival incision. The options for repair are, now the most commonly ones used are the methyl porous polyethylene or a titanium sheets. So these titanium sheets can be cut and they can be bent according to the shape of the floor. And you can bend it according to the last bend you can see here. It's not coming. It can fit into the inferior orbital margin. So this is a short video. I have already exposed the inferior orbital margin. I am sitting at the head end of the patient, and the video is taken through an operating microscope. You can see the large fracture and all the tissues which has prolapsed into the maxillary sinus. By hand over hand technique, you have to release the tissues, and you may have to punch the edges of the fracture to enlarge the fracture, and then only all the tissues can be released. This is an old video. I am using a silicone sheet here. So the silicone sheet is a little rigid, you cannot bend it. So whatever you place there, you have to, here I am using a glue to fix it also. So whatever you place, whatever implant you place in the orbit, cover it with the periosteum. So suture the periosteum well, so then it doesn't extrude. With I think 40 Vicryl, the periosteum has to be sutured, and then the conjunctiva is sutured. So subciliary incision will give a good exposure and also a minimal scarring. Conjunctiva, when you do your assistant's hand will start aching, because so much you have to retract to get to the floor. So subciliary incision is good enough. So when do you not do a repair? When there is absence of diplopia in the primary or reading position, there is no significant ophthalmos, and if the fracture is small. So in this case, when there is almost normal lid movements, eye movements, and this fracture is small, should you do a surgery? Marian is there. Will you do a surgery here? Movements are almost full, but always do a diplopia chart. Diplopia chart may reveal hidden diplopia when you are dissociating the two eyes with different colors. Medial blow-in fractures, there may be muscle medial rectus entrapment. The medial rectal, the abduction may not be that much restricted. There will be epistaxis. CSF leakage should always be asked for. The patient will say, I have a cold, I am running nose through, I am having watering from one nose. So you have to suspect CSF leakage. All these mistakes have happened with me, that's why I am really. So undetected fracture, this was, patient came with an NLD block mucocele. So I just took a CT, it was a fracture, undetected fracture. Zygoma maxillary fracture, there will be a malar flattening, lateral canthal drooping, there may or may not be globe displacement. Traumatic optic neuropathy can be seen in 0.5 to 5% of orbital trauma. So traumatic optic neuropathy is a short note, can be asked. I don't know if there are any PGs here. So these are the different causes of traumatic optic neuropathy. Blood in the sphenoid sinus is an indication that there is a traumatic optic neuropathy. Superior wall fracture, when the patient comes with ptosis, defective elevation, you have to think about superior wall fractures. This is again another superior wall fracture with enophthalmos. All these were detected only on imaging for enophthalmos. So when the vision and hand movements, stasical eye, large fracture, I don't think I'll repair, I'll just put in an artificial eye. This was again another dilemma. Metallic foreign body at the apex, double perforation. No need to do anything. No. I sent it to LVP when they started navigation, but they too didn't do anything. Thank you.
Thank you, Annie ma'am, for this presenting this very useful topic. Then next I would like to invite Dr. Marian Poli madam. She doesn't need any introduction. Currently she is working as a consultant oculoplastic surgeon at Giridhar Eye Hospital. She'll be covering two topics. One is a logical approach to vascular lesions of the orbit and an overview of orbital tumors. Actually, the last topic was supposed to be taken by Dr. Maneksha sir. Unfortunately, he couldn't join with us due to some health issues. So, Marian madam will be covering that topic also.
Yeah, good morning. Thank you, Dr. Aparna, for putting up this IC. So, vascular lesions of the orbit, I just see practical approach. There are two broad categories. One is tumor, where you get a proliferative endothelium. Second is malformations. So malformations, it's a localized defect in the vascular morphogenesis that can be either in the artery, vein, capillary, lymphatics. Here there is no cellular turnover. So that's the difference between a tumor and a malformation. Now lots of research is going on in this area. That's why I just put across the slide. So malformation again, as I have already told, venous can be varices, cavernous venous malformation, intraosseous venous malformation, capillary port vein stain salmon patch, then AV malformation and AV fistula. Even though it present to us, we need help from interventional radiologists to treat these two. So vascular tumors, the most common which we come across is infantile hemangioma. It is called capillary hemangioma of infancy. Here we have to it's always a clinical diagnosis and we have to understand the natural cause. So usually the child will present around 3 weeks to the small reddish lesion. Some days it can present early also and it will start gradually growing. So most of the time when the parents present to us around 2 months or 3 months, and you can get the old photographs and see the natural cause. So then what are the indications for treatment? All the lymphangiomas does not require any treatment. So you have to refract all these babies. anisometropia, then any ptosis causing obscuring the visual axis, rapidly progressing hemangioma. So from the old photographs, you know whether it is rapidly progressing or not. If the growth pattern in the last 2 weeks, then you can predict what's going to be the growth pattern in the next 2 weeks. And any surface ulceration, exposure keratopathy, and optic neuropathy. So treatment is by oral propranolol. So in my practice, I never start by myself. I always get an opinion from the neonatologist. Starting with the low dose and increasing depending on the response. For me, everything is done by the neonatologist. I just follow up the baby every month till it start regressing. So if it is responding, it will show the first sign of regression after 3 days. I usually combine with topical beta blocker also. So this Timolol-Toddy, I don't have any financial interest. So Timolol-Toddy drops is freely available. What I do is ask the mother to mix with some gel, lubricant gel, and apply over the skin at least twice daily. It also adds to the result. Then systemic and intralesional steroids are described and surgery is also described, again when it is not responding to the propranolol. So this baby was started on propranolol initially, but it was regressing, but still it was causing -4 cylinder. So I went ahead and operated to prevent amblyopia. This is a very ulcerative large hemangioma. So we were also actually wondering what can be done. So we treated with antibiotics, steroids, propranolol. I was planning for a debulking, but during the meantime it ulcerated by itself and then healed. And baby is having a mild ectropy on now. Coming to the malformations, so vascular malformations, the most common malformation which we come across is cavernous venous malformation. So we always call it as cavernous hemangioma, but the new terminology is orbital cavernous venous malformation. So simple venous malformation seen in middle-aged, like 30 to 50 years. Here also clinical course can be asymptomatic. So most of the time they don't come with I have got hemangioma. They always come for mild protrusion or sometimes some blurring of vision, or the refraction is getting frequent change in the refraction because of the hypermetropia. So clinical course can be asymptomatic or symptomatic. And treatment is there are some indications for treatment, like especially it is affecting the vision or visual fields or optic nerve is compromised. We had to excision biopsy is the treatment. So actually in this, she is a 44-year-old female, presented to OPD for a glass prescription. So she noticed this protrusion and she was already undergone thyroid function test. Thyroid was normal. Then, so she was just sitting like that, but I couldn't put her refraction. She had +1 hypermetropia for the distance in the left eye, and the disc also showed a minimal disc edema. So did an imaging and diagnosed as cavernous hemangioma, and then we removed it later. So this is, I'm just showing basically all cavernous hemangiomas, we always cryo-assisted extraction after doing the lateral orbitotomy. The main thing is, like, if it is an accessible quadrant, it is very easy. Otherwise, you have to combine 2 approaches, lateral orbit and lid split. So she is doing well at 3 months. So coming to the next most common one, that is lymphangioma. Lymphangioma is called veno-lymphatic malformation. Again, microcystic, macrocystic. So seen in younger age group. So treatment is again same as like it is affecting the vision, sudden onset proptosis. So most of the time the thing is they will say it is increasing with respiratory infection. So that gives a clue to the lymphangioma. If it is a chocolate cyst, then you can excise. So similarly, he actually presented to us acute onset proptosis, had compression, minimal compression with relative afferent pupillary defect, but vision was holding. His IOP was also high, so I started on oral steroids. And after 3 weeks, it has localized, and then we injected bleomycin, excision and bleomycin injection was done, and he did well. Coming to varices, varices presents with intermittent proptosis. Visible, someday you can see visible lesions. The complications here you can expect is either you can go for a bleed or you can thrombose. Thrombus is good, bleed might not be. So treatment is surgical excision assisted with the glue or endovascular embolization. Usually we do when there is a recurrent thrombosis, pain, severe proptosis and optic nerve compression. So this is one localized varix mainly involving the anterior orbit from the scans and the conjunctiva. We excised it and it will bleed, but it is usually venous, so it's easy to control it. Similarly, you can see the phlebolith. This is a thrombosed varix. Her main problem was whenever she stoops down, it will come off and was creating lots of trouble. So again, we did a surgery to a transconjunctival approach, and she did well. Coming to the intraosseous malformation, this is a little tricky. So this is a young patient presented with acute onset proptosis. So scan, you can see there is a well-defined lesion in the superior orbit. At the same time, you can see a small defect in the bone with the lesions in the frontal bone also. We actually thought of, when we saw this defect, we thought of something inflammatory, but we intraoperated, it was bled, and then removed the bled and cauterized the lesion. But he had a recurrence recently. I'll just share one case. Like vascular tumors are always very tricky, even though this is one patient, 28-year-old, left eye proptosis 5 years, treated as lymphangioma with the sclerotherapy, with the bleomycin, cyst aspiration, etc. 10 times. So this was a CT scan. So you can see some cyst, and there is a solid component also. So initially we also thought it as probably we will go ahead once again. And she was doing Ayurveda also in between. So during the, we posted for her debulking cyst aspiration, we did a biopsy, but initial result was hemangioma. So again, we were also confused, is this hemangioma? So then we looked into her old MRI, so this was her initial lesion. So this was not characteristic of lymphangioma. Then we did a repeat biopsy and did immunohistochemistry. It turned out to be solitary fibrous tumor. So further she underwent DSA, interventional radiology, tumor embolization followed by surgery. So vascular tumors is very, very challenging sometimes, and the clinical presentation is also variable, acute onset proptosis, sudden loss of vision, etc. Diagnosis itself is challenging, so as the treatment, and needs logical approach in almost all the cases other than probably capillary hemangioma of infancy. Thank you. Any doubts regarding vascular? Anytime?
Madam, have you used sirolimus in treating lymphangiomas?
No, not it. Adalla. Manisha. So this is one last minute call which I got yesterday at 11:30 p.m. So I will try to do my justice. Orbital tumors, just an overview. So I thought of like orbitis, we know it's a Pandora's box. Here the clinical presentation matters. See, orbital tumors, the thing is nobody will come and tell you I have got a tumor in the orbit, but at the same time in the lid they will come and tell you there is a tumor. So now you can get a myriad of clinical presentation. That's the most important thing. And there are very subtle signs. So if you look at her, she actually was roaming around with a chronic periocular pain. So we treat lubricants, then steroids, this oral NSAIDs, probably ocular migraine, treat like migraine. So then since it was not responding, then we did an imaging, turned out to be a cavernous hemangioma. So this is one very important thing. It's when the patient presents with chronic pain and not responding to a routine line of management, better to get an imaging done. Again, unilateral lymphedema in elderly. So if you look at her, you can see this fullness. Look at left eye, and the globe is little displaced down. So this is not allergy, this is an orbital tumor. Again, similar case. Again, he has not noticed his proptosis. He just came some sort of fullness in the upper lid. Again, this is not allergy. Get an imaging done. So this is another patient. She's already a known case of CA breast, treated long time before, like 24 years back, but she had a mild ptosis. So now the thing is, there was diffuse soft tissue in the supratemporal quadrant. So naturally we can treat it as dacryoadenitis. Since she had a history of CA breast, we thought a little something out of the box. It was a metastasis. Again, with inflammatory symptoms, this we have already seen from Dr. Aparna. It was a case of lymphoma. So I'll just quickly pass through. These are the few presentations. Coming to the neural tumors, this is my first case, this optic nerve glioma. This is a 2-year-old female child with optic nerve glioma. Diagnosis is quite straightforward in gliomas. So initially when the child presented, we thought of observe for 2 months because all the gliomas does not require any treatment. Some of them will spontaneously regress. So they had increase in proptosis, MRI radiologically also increase in proptosis. Meanwhile, get a genetics done for neurofibroma. It was positive for neurofibroma. So since it is increasing, then advised chemotherapy. So by that time, the proptosis has been like this, and the child had lag of thalamus also. So child was started on chemotherapy by the pediatric oncologist, and the child did well. So she's still with us at 3 years follow-up. So the left eye vision has improved to 6/24, even though the disc is pale. So gliomas, if progressively increasing, you have to treat. There are lots of controversies in the treatment because most of the time the patient will be referred to the neurosurgeon. They will directly do the surgery. The thing with surgery is there are some specific indications. Cosmetically differing proptosis, no possibility for vision, and causing gross exposure keratopathy. So with surgery, definitely the child become no PL. But chemotherapy, again, there is a possibility to at least retain the vision. So coming to the schwannoma, again here the diagnosis itself is very, very challenging sometimes. Most of the time radiologists will report it as hemangioma. So we also think could be hemangioma, but I will show you this hemangioma will have some characteristic radiological pictures. So treatment is always surgery only. So coming to mesenchymal tumors, rhabdomyosarcoma, the child presented with swelling after a fall. So it was like a kind of masquerade. But if you look at the scan, you cannot see the superior rectus complex separately from the mass. So it is something that arising from the muscle. So we thought of rhabdomyosarcoma, did biopsy and later he underwent radiation also. Lymphoma is the most common orbital tumor, myriad of presentations. So the thing is, our aim is to do the diagnosis, and most of the time it is isolated to the orbit, then do orbital radiation, and they will do well. But the patient has to be kept under follow-up. So this is like, the thing is, we have already seen, like sometimes it starts as inflammation and then it changes to lymphoma. So that is very, very possible. So always keep the patient under follow-up. So this patient actually 7-8 years was on steroids, on and off. But if you look at the radiology, you can see this mass lesion, it is actually embracing the globe. So something that embraces the globe is mostly in favor of lymphoma. Coming to lacrimal gland tumors, benign is pleomorphic adenoma. Excision is the treatment. Adenocystic carcinoma, the thing which we cannot miss. You can see why it is adenocystic. There are some bone erosions. Globe indentation is also there. Lacrimal gland is not seen separately. So she underwent excisional biopsy and treatment later. Treatment is by the lateral orbitotomy. Take traction sutures and muscle sutures are also taken just to retract the globe. Then lid crease with the extension to the lateral part. Reach the periosteum. Then I always mark the periosteum, then incise the periosteum with radiofrequency cautery, or you can use number 15 blade. Put backwards, then reflect the periosteum. I was using chisel and hammer before, and slowly moved to striker. Now there is a small incision in the fascia. Expose the orbital contents. Look for the tumor, do blunt dissection. And you can use cryo to remove the tumor and then close it. Coming to secondary tumors can come from eyelid sac, conjunctiva, then intraocular tumors with extension to the orbit, paranasal sinuses, and metastasis. Everything like once you diagnose, it's easy to treat. In fact, this patient was treated as scleritis, but if you look carefully, there was a globe displacement laterally. So you can see when the scan showed it's a malignancy involving the paranasal sinus. So this patient also very subtle findings only. He had watering, so coming and going with the lubricants, etc. But this proptosis will needs imaging, and again sinus malignancies. Lacrimal sac lymphoma is quite common. You can miss when there is a suspicion of any malignancy, especially when the sac is very thick during DCR. Better to do biopsy, and sometimes you can miss lymphoma sometimes. Metastatic tumors, 8% of orbital tumors, most common in women, especially breast. In male, it is prostate and lung. So this is just an overview of the orbital tumors. The main thing is orbital tumor is diagnosis, because radiology can be like very confusing. So we should be able to learn our own or read our own radiology. That gives the clue. So anatomy is very complex and broad range of diseases, and team approach is always needed. Thank you.
Thank you so much, Marian ma'am, especially helping me at the last moment by accepting the challenge yesterday midnight. So now it is open for discussion. Anything to ask?
If you got a suspicion of adenocystic, do under frozen section. Yeah, I mean almost whenever an element of even that vascular tumor which I showed, that young guy, we were also very confused whether it is vascular or inflammatory, because if it is inflammatory, do frozen section and you can inject intralesional triamcinolone at the same time. So in fact we planned for frozen section, but when I opened it was a blood. So whenever in a doubt, do frozen section. It's take only 20-25 minutes. I aspirate and then inject. Yeah, my first investigation is always CT scan, but the only contraindication is like optic nerve tumors. So in that case, you will have an RAPD, axial proptosis, and the age group is also like pediatric. When the child, we didn't do CT, we just directly went for MRI, because we are more or less quite sure it is optic nerve glioma. So that's one condition where I do MRI as first imaging. Otherwise, most of the time we go for CT scan only. Yeah, fistula, we are suspecting vascular lesions, we can, but the thing is, after CT scan only you know this is like whether it is vascular or a solid tumor. So if the vascular tumor, then they will go for send for MRI with MRV. So again, CT scan is the first investigation, because like, again money also matters, no MR.